The following audio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak to a healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Hey Thal Pals, it's your friend and patient advocate, NinaMaria, along with my co-host, Dr. Kevin Kuo, and you're listening to Thal Pals, the Alpha Beta Revolution. Today's topic is stages of life with thalassemia. We'll be diving into what it means to be an adult with Thal, some of the common challenges that patients will be presented with, and how to tackle them head-on or prevent them altogether. Today we have our guest, Dr. Scott Peslak. Why don't you start by just introducing yourself and kind of give us your background when it comes to Thal?
Sure. So my name's Scott Peslak. I am a physician scientist at the University of Pennsylvania in Philadelphia. I have been studying red blood cells for 20 years since my PhD work in the University of Rochester, where I got my MD PhD. When I came to the University of Pennsylvania, I really became interested in trying to apply the study of red blood cells to specific patients and to really be able to try to develop new therapies for red blood cell disorders. So I really became interested in sickle cell disease and in thalassemia. I started my lab at the University of Pennsylvania about 2 years ago. I study sickle cell disease and thalassemia and new ways to develop therapies to increase the fetal form of hemoglobin. We can talk more about that. And I direct the Adult Comprehensive Thalassemia Program at the University of Pennsylvania, as well as lead the gene therapy efforts at UPenn.
I didn't know you went to Rochester. Did you do the TIC4 program?
No, I did. I went to my undergrad. Actually, was the University of Scranton, which I would say that very small liberal arts school, but I learned a tremendous amount about how to be able to interact with other patients, with other providers, with the community. And when I came to the University of Rochester, I was through the combined MD PhD program there.
Well, I think that's the reason why you're able to go from bench to bedside.
Yeah, I would say one of the things that's been the most important aspects of my career that started at the University of Scranton and continued through University of Rochester and UPenn is really a commitment to the whole person. Not just saying we're going to study this particular disease. We're going to study the whole person. We're going to treat each individual with a complete understanding of who they are, what their goals are, and how we can bring new therapies and new advances in the field to that patient in a very individualized way. As you both know, it's easy to say, yeah, let's just give gene therapy products to everybody, or let's do this therapy for everybody else. But every patient is individualized and every patient is different. Yep. So understanding what patients need, where they are in their life, and how that impacts the decisions that are best for them is really critical. And my training throughout has really provided me the perspective to be able to help patients make those decisions in an informed and impactful way.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, partners, and each other. Building on these connections and the company's unmatched leadership in PK activation, Agios is pioneering therapies for rare blood disorders, including PK deficiency, thalassemia, and sickle cell disease. To learn more about thalassemia, visit rethinkthalassemia.com. To join the conversation with other patient allies, follow us on Instagram at Ally Voices Rising. That's Ally, A-L-L-Y, Voices Rising.
Speaking, about where patients are during the life, right? Let's start in the 20s. So you told us that you run a comprehensive care centers for people with thalassemia. So tell us about what patients in the 20s experience in terms of thalassemia.
That's right. So in terms of patients coming to us in their 20s, this is a very, challenging time in many patients' lives because they have been taken care of by the same pediatric team for their entire life, right? And pediatric centers, as much as we'd love adult centers to be the same as pediatric centers, they're very different, right? We don't have things like child life, and we don't have the same closeness of resources, but we have a different way of helping patients. So I think this transition and the benefit of transitioning to an adult program is that we can provide lifespan care in a very different way than pediatric programs can. Pediatric programs are really allowing for decision making between the child and the parents. And as that evolves, we want to allow patients to grow and make decisions in an independent way that gives patients agency and direction and mission in their own care. And so that transition to an adult program allows for that way in a way that patients can really expand how they view thalassemia and how they can care for themselves in a comprehensive way. So I think the biggest challenge is finding adult centers. To be perfectly honest, there aren't that many in the country, and many thalassemia patients are still taken care of by their pediatric providers, who are amazing and incredibly dedicated to their patients. But it's difficult to have the same provider that is focusing on aspects of care from a patient that's 2 years old versus somebody that's 60. They're very, very different approaches. So I think connecting with your pediatric team and allowing them to connect with other adult centers that can transition your care appropriately. And I would say that, one of the key things that we always say is it's not transfer of care, it's transition of care, right? Because transfer of care is just saying you're going from pediatric to adult center. Transition of care is really a comprehensive way to do this. So we do this regularly with patients. We meet with my colleague, Dr. Janet Kwiatkowski at Children's Hospital of Philadelphia, to be able to transition patients regularly from CHOP to UPenn. We talk through the social aspects of their lives. We talk through some of the challenges they might have. If they have any psychiatric concerns, and they're being seen formally by a psychiatrist or psychologist, or they're just, have the typical stressors of being a young adult, these things we talk through and make sure they're prepared for this. My incredible thalassemia nurse coordinator, Jenny Cohen, helps tremendously with moving patients and ensuring patients are ready for this transition. And then when patients are available and able to do this in a proper way, we then transition patients over to the adult side. So I think it's ensuring that patients are ready for this transition, and ensuring you have a team on both the pediatric side and the adult side that can provide that necessary guidance and education to be able to do this in a smooth and effective way.
That's awesome. I think it's really important how you noted the difference between transition and transfer. I think it might not seem like it at first thought, but it can really be a very jarring move and change in a patient's life to go through those differences of care. Like you mentioned, it is very different, and it's scary. Yeah. And so I think having that team effort and that slow, gradual transition can make all the difference for a patient.
And I would say one of the things we regularly do is one of the key aspects of care, in addition to the thalassemia team, is the transfusion team, right, and the apheresis team for our transfusion-dependent patients. And so we will have them meet our apheresis and transfusion medicine team on the adult side well before we do the actual transition of care. We want to make sure they're as comfortable as possible coming to a brand new space where, for transfusion-dependent thalassemia patients, they're going to be coming every 3 weeks to get their transfusions, right? We want to make sure they're comfortable, they are respected for the individual that they are and what needs they have from both a medical and a social perspective. And they also have the best experience possible in performing that transition. So meeting that team is also a really critical part of our process too.
Awesome. You did mention that a lot of patients don't have access to adult care when it comes to thalassemia, right? A lot of us see pediatrics still, and like you said, great facilities, but very different, and are focused on different needs. What is your advice to patients out there who just don't have access to adult care and are seeing a pediatric team? What can they do to better ensure adult care in their own life?
Yeah, that's a great question. So I think I would say on my end, I am trying very hard to help educate and recruit the next wave of physicians, clinician scientists in hematology. And I'm very proud to say that we've done this tremendously well at Penn, and many other centers are doing this well as well. And so this is really critical. We need to increase the number of adult hematologists that are dedicated to our population of thalassemia patients. And I think the more that we have new research and new therapies that are coming into the field, the more excited people will be to be able to do this. So I feel this wave of energy coming through even at ASH this year with new things that are exciting for young physicians to be able to come into the field to take care of our patients. I think from the patient perspective, I would say it's challenging because there are so few centers, but I think one of the key aspects is being in and associated with, or at least having your provider discuss with a comprehensive thalassemia center. So, many of our patients, including in our center, are transfused not at Penn. They're transfused their local hematologist, and they see us for their overarching comprehensive care. I think that model is really critical to be at a place that is comfortable with transfusions. But on the adult side, if you are getting transfused as a patient outside of a comprehensive center, it's really important to connect with a comprehensive center to be able to get that overarching care at least once a year. And there are many centers and resources available through ASH, through Cooley's Anemia Foundation, through many other resources that can provide the contacts to be able to connect with a comprehensive center. So it doesn't have to be for every transfusion, but it should be at least once a year to be able to provide the context for how patients can ensure they're getting the proper comprehensive care for their thalassemia.
So a corollary question to the experience of people in the 20s is that many do go away for the undergraduate or graduate studies. Some may move away for work, for example, and sometimes it's not permanent. They move away for like a couple of years, 3 years, just to see how things go and then move back. How do you help those patients who move away from your center?
I think this is why the close network of thalassemia providers in the country is so critical. Mm-hmm. So I can tell you that we have one of the best ways there's several ways we do this. One of the most effective ways to do this is a model called the ECHO model. And this was actually pioneered way back in the 80s with other kinds of infectious disease disorders, but it's been expanded to sickle cell disease and particularly thalassemia. And so we, along with Dr. Kwiatkowski and Dr. Sujit Sheth and myself, we lead one of the ECHO sessions on the East Coast, and there's many throughout the country. And this allows us to understand thalassemia better, and to provide some continuity across different regions and different areas. And so I think that provides networking and the ability for us to discuss, if somebody is moving to a different area, who are the key thalassemia providers that are there. This is kind of a hub and spoke model, right? And so that there's major centers that discuss this with patients, but then there's other providers that come to these sessions to learn about thalassemia. So we use that as an opportunity to understand who are the hematologists throughout the country and in other areas that have an interest in taking care of thalassemia patients, that understand some of the biology underlying thalassemia and are committed to our patients and our population. I think that's one way that we can do it. The other is that we can take patients, or we can take, ideas from patients about where they're going, and we actually reach out to centers in other areas to be able to understand that as well. So if they're moving to a new area, we do a lot of work trying to understand how patients can get the proper care they need in different areas of the country with the connections that we have. So it's really a relationship between patients and providers to understand where is the best area for patients to be seen, who is the best provider that's really committed to our population, and key and frequent communication to be able to talk through that process.
Being in your 20s is a transition period in many different ways, and when you have thalassemia, this is a major one. Let's move on to our 30s and 40s. So once we have patients who are in adult care, what are some of the challenges that you see specifically in that age range?
Yeah, great question. So I would say that one of the biggest challenges that we see is deciding what is the overarching care plan for patients that are moving into their 30s and 40s. Many patients who are transitioning from pediatrics to the adult side, we kind of keep the care plan similar to what they've been getting. That if they're getting well transfused, the key parts of, and we could talk more about this in a little bit, but the key parts of ensuring that patients prevent any kind of long-term complications and have the best long-term outcomes for thalassemia is transfusing and maintaining a pre-transfusion hemoglobin of greater than 9.5 to 10. That's really become the gold standard in the field. And so, well transfused patients and staying on top of transfusions is really critical. But I would say the biggest challenge that happens when patients get into their 30s and 40s is, should I do something different, right? And I think the big question that many patients have is, should we be pursuing transfusion therapy, different pharmacologic therapies that are emerging in the field, or gene therapy? That decision point between each of these processes is really almost existential for many patients, right? Understanding what does it mean to take care of my thalassemia independently into my young adulthood. And so it's really important, I think, to address that pretty frequently with patients. You don't want to, not every visit necessarily, but once a year saying, how are you doing, right? Instead of just looking at numbers and saying, here's your hemoglobin, here's your ferritin, here's these values, saying, how is your life? How are things going in your life? How is thalassemia impacting your job, your ability to have children, taking care of your family? And so I think really addressing those aspects of care in patients in their 30s and 40s is absolutely critical. And it involves a comprehensive team. So our team, as I mentioned, we have a phenomenal nurse coordinator, but we also have a psychologist as part of our team. We have a social worker involved in our team, and we have a tremendous set of nurses that take care and LPNs that take care of our patients. And so we ask those questions in different ways at different times for patients. And I think I often say, as a physician, as a thalassemia physician, in a patient coming in, I might be the least important person that the patient is seeing that day. That my patients might need social work support. They might need psychological support. They might need a different aspect of care. And so, really, this comprehensive model is critical, and ensuring that is in place for patients in their 30s and 40s to be able to make informed decisions, to understand what is going on in their lives, and how we can choose therapies that best match where they are now and where they want to be and what their goals are is absolutely critical.
So, given what we have just talked about, do you see an age where you start to see there's more complications? And does the way in which people manage their thalassemia matter in terms of when we start to see complications?
Yeah, it's a very important question. I think I would say, as is most things, it depends. But yes. I would say that, as I mentioned just a minute ago, ensuring that you are achieving appropriate transfusion goals is really the number 1, 2, and 3 things that I make sure in my patients that I'm achieving, because we know long-term and data that's recently been released and published that achieving these pre-transfusion hemoglobins of greater than 9.5 to 10 is absolutely critical to ensure patients not only to ensure patients we reduce long-term complications on patients, but also just to improve quality of life for patients, right? In general, patients feel better when they're well transfused. I would say that into patients in their 30s and 40s, many times patients have other things going on in their lives, and it might be more difficult to come every 3 weeks for a transfusion, or in patients that need higher transfusion targets because of more complications or more fatigue or other symptoms, it can be difficult. And so that is oftentimes a time in patients' lives where it's more difficult to achieve those goals because life happens, right? And so we want to be able to, the whole goal of our field is to develop new and better therapies to help patients address and to live their life, right? And to allow their life to happen in a way that doesn't impact their quality of life. So I do think that time period is challenging. The other major issue that I think can happen in patients in this age is iron overload. Historically, it was difficult to achieve higher transfusion targets because we didn't have great ways to remove iron from the body. And now we have several really excellent ways to remove iron chelators, that even if one of these has side effects, we can use a different one to be able to improve patients' care. But it is difficult to take, if you told me you have to take a medicine twice a day, every day, I'm not sure I'd be able to do it. It's really hard. It's very difficult. And so I think recognizing that for our patients to say, this is something you need to do twice a day, every single day for the rest of your life, that's a hard ask for patients. And so giving them all the resources and opportunities to be able to support them through that is absolutely critical. And if we can reduce the amount of chelation that we need in a variety of different ways, that can be really beneficial, because without proper chelation, this can affect many organs in the body, particularly the liver and the heart. And so this is the thing that I worry about the most. And in that age range, it becomes more difficult to achieve the right levels of iron in the body. The other barrier, especially for women who are thinking about fertility preservation as they move into their 30s and 40s. To do this requires you to stop your iron chelation for an extended period of time. And so that is a major challenge. That becomes, holding iron chelation for a year and a half for ovarian collection or for fertility preservation, it can be problematic in terms of the level of iron that can accumulate and to be able to have to catch up on the back end for that. And so I think this is a thing where life and many things happen in this time period. And so supporting patients through this time period is really critical.
Yeah, and it's not just about taking the iron chelation, isn't it? It's also about the monitoring, right? The blood work, the multitude of blood work that people have to do. And in addition to that, the scans as well, and the visits and so on and so forth. It just sort of piles on. And then all the paperwork that's associated with all that, and the juggling of commitments and appointments.
Mm-hmm. It's all the little things that add up and weigh a patient down.
Yes, exactly. Yeah, it's sort of the straw that breaks the camel's back, and you don't know exactly which one it is, but they do add up.
Yes, and staying on top of that can be very challenging, both from a patient, from a provider, from an insurance perspective. These things are all very challenging, but I would say that it is in the two critical things that are the most important for patients to know around this time period in the 30s and 40s is, proper transfusions and iron chelation. That's the take-home message from that age range that I'd say is absolutely important.
So patients with Thal are living longer now than ever before, thanks to new treatments and a better understanding of the disease. Folks are living in their 50s, 60s, beyond. With this kind of newer age group, what are the complications you're seeing, and what can patients do as they lead into those years to better support their health?
I am incredibly excited for the thalassemia community and proud, particularly of our patients who have worked so hard to be well transfused, to chelate their iron, to see their endocrinologist to take care of other complications like osteoporosis and diabetes and many things that can occur in older patients with thalassemia. But I think it's important to remember that patients with thalassemia in their 50s and 60s can have other things happen to them as far as life as well. And so, we're understanding this more and more, that the things that can happen to patients, risk of certain kinds of cancers, risk of age-related diabetes, age-related osteoporosis, heart disease that is not related to iron overload, but simply related to patients being in their 60s, 50s, and 60s. These are really important. And so that's why it's really, really critical for patients who are, I would say, over the age, throughout the age range, but particularly patients over 50, to be able to be associated with a comprehensive adult thalassemia center, because these are the kinds of things that pediatricians don't see, right? They don't take care of age-related atherosclerosis or heart disease, and so having the ability to screen for these and have the providers that know how to take care of these complications as patients age is very critical, and it is something that is important. But I would just reiterate, it is incredibly exciting for our community that we have many patients, dozens of patients now in our practice that are over the age of 50, 60, some into their 70s. It's patients are not only surviving but thriving, and they're doing so with the incredible research and dedication from the entire thalassemia community.
And Scott, if I may add, we're sort of entering in a technical speak, an evidence-free zone, meaning that there hasn't been a lot of literature that's dedicated on how older adults with thalassemia thrive in their 50s and 60s. And so to me, I think part of the effort, us as a group, between patients and the providers, is to be able to gather that evidence and to be able to share their knowledge and how they are living in the 50s and 60s with the world. I think that's very important as well, so that other centers can learn as well.
I agree. I think the initiatives that are being done at the regional and the national level are really critical. I can tell you at the regional level, we have a thalassemia registry that we have initiated through Penn and CHOP, where we are trying to collect the broadest age range and the broadest collection of therapies that we possibly can to understand not only how patients are from a quality of life perspective and a patient perspective, but also how their different markers change over time, and how that changes with different therapies that we see. So we actually have an abstract here at ASH that's being presented later on this weekend about this, and I'm very excited with this initiative because I think this and many others that are being promoted by ASH, by Cooley's Anemia Foundation, by many other organizations at a national level are really critical because we need to, you're absolutely right, this is a data-free zone, and we need to understand what is the natural history of thalassemia in patients that are well transfused and well chelated into their 50s and 60s. We don't know. And I think it's an incredible opportunity for research and an incredible opportunity to engage our really research and advocacy-minded thalassemia patient community. The patients that I've approached about this have been overwhelmingly excited and positive to participate in studies like this because we want to be able to help each other. All aspects of the thalassemia patient community and the provider community. It's very collaborative. And that's, I think, the most rewarding aspect of what I do is just the camaraderie and the connections that we're able to form across many different patients and many different providers and across the entire age spectrum. And so I agree that it's absolutely critical, and we and others are really trying to promote this moving forward as well.
That's awesome. Thank you so much for lending your voice and just this push for, better adult care and health, something definitely needed within the community.
Absolutely.
Absolutely, Scott. And thank you for being such a great advocate.
Thank
really
you.
Appreciate
and thank you both for really, representing the thalassemia community tremendously and providing really high level and advanced care for thalassemia across the country and across the world.
So thank you for the very amazing discussion today, Dr. Peslak. And with more thalassemia patients living well into their adulthood and reaching the older ages, I think it's really important for providers like you and I, how we can figure out how to optimally engage our patients and also to help our patients to manage their thalassemia. Don't forget to like and subscribe to the show, and we'll see you next time at Thal Pals, the Alpha and Beta Revolution.